Welcome to the RegenMed SAGA, Stories from the Front. I'm your host, Leah Braddell, CEO of DataBiologics. We have a great guest today, Dr. Tom Nabity, who's going to share his story from the front lines in regenerative medicine. What's your background? How'd you get into regenerative medicine?
Long story short, switched into PM&R, and via PM&R, got into more the physical medicine portion than the rehabilitation portion of PM&R. And there's a lot of pain in the physical medicine. So I decided to do a pain medicine fellowship afterwards. Really enjoyed the idea of trying to get down to people's drivers of their pain, their specific source of their pain, putting a little dose of medicine, cortisone, lidocaine for the most part, doing minor procedures like radiofrequency ablations. But then got into the 2016, 2017 timeline, and regenerative medicine was really starting to show up in literature as options. Had patients starting to ask about it, and did a search in Metro Detroit and really didn't find anybody that had the right skill set as far as a needle driving skill set and a background with sports medicine or musculoskeletal medicine doing it. So did my first course at the American Academy of Orthopedic Medicine, AAOM, and down in Louisiana, and had my mind just wide open. And from then, I just decided to commit towards a slow and steady transition away from pain and towards regenerative medicine.
Are there any things that you've just totally abandoned in practice since you've adopted regenerative therapies?
Good question. I don't prescribe opiates anymore. I did just, it's not a part of pain medicine that I really ever enjoyed. I think there's a place for it. I think they have their role. I don't think they're absolutely the evil, tool that should never be used. They definitely have their place. But I've just decided that that's not the part of the practice that I want to do anymore. And so I've decided to let that part go.
It seems like, that transition going away from spine surgery as the primary treatment, like this is something that could be really in between for a patient or a stepping stone to avoid or delay that surgery. And it really makes me think of, I spent many years selling robotic surgery and being in the operating room with physicians, learning these new techniques and, transitioning away from, really morbid procedures where patients sometimes were, affected forever with the outcome of that operation. And then suddenly these procedures were minimally invasive and people are going home the next day and really feeling, very, very little pain. And I'm wondering if there's a similar kind of transition that you're seeing in your field and potentially in the spine area. And what does that process look like for physicians who want to train in new technology like this?
Yeah. So it's definitely moving into our field, the pain management field, if that's kind of our field that we're talking about, where more and more of my colleagues are getting interested in doing this. And it's not, it really truly is not money driven. It is outcome driven. It is because they see patients who get relief from a pain block, but it comes back. Get relief from a pain block, but it comes back. They've done the physical therapy. They don't want to take drugs. They want to get better. They want to maintain their job, their livelihoods, their their hobbies, and they enjoy things that give them enjoyment in life. And they really don't want to have surgery. They just don't want that risk. So the niche is there, the demand is there from a patient base, the desire for physicians to acquire these skills is exploding. And so what's the process, I think was the question, like how does it
how do you
from where I was?
How do you get that training?
Where I am. There's really good societies coming out. I mentioned one of them earlier, the AAOM. The other, the Interventional Orthobiologics Foundation, another one, TOBI, TOBI. And that's just to mention a few. I don't mean to, if I've excluded other ones, I don't mean to by means of, I think they're bad societies. Those are just the three that I'm most involved in and feel like have really good people behind them, those that founded them, their mission, their goals, what their values were, why they wanted to promote regenerative medicine in the first place. And I would highly advise anybody, just do what I do, go to a conference and just let your mind be blown too. Just get around like-minded people, watch the presentations on the symposiums, feel that energy, feel that just wave of, this is reality. This is what's happening. And the first conference I went to, there was I hope I get his name right, but a guy by the name of Lenny Johnson, who in 1970s was one of the first orthopedic surgeons to incorporate this thing called the arthroscope.
Yeah.
And way back then, right, it was not covered by insurance. It was experimental. He was told he was using the tool of the devil. He was actually thrown out of his American Academy of Orthopedic Surgeons. He lost his hospital privileges, but he had people flying, professional athletes flying to come and have it done because they wanted less downtime. They wanted a quicker recovery. And he's like, I know what I'm seeing. I know the outcomes I'm getting. I'm just going to keep doing it. And, time was on his side. Now everybody does scopes, right? He got the Lifetime Award for the American Academy of Orthopedic Surgeons. He obviously got all his privileges back. And now he's, a legend.
That's such a great analogy. I was part of that early adoption of robotics, and it was the same thing. It was, this is unproven, what are we doing? This is not, safe. It can't be covered. It can't be reimbursed. And now if you're a hospital with an operating room, you have to have a robot. That's the standard of care. And the same was true for laparoscopy. The first lap chole was an 8-hour, big ordeal. And now it's the most routine procedure ever.
Surgeons race to see who can be the fastest. Right?
Yeah. No, it's just, so that's what's drawn me into this field now. And especially looking at the data aspect of it. I think that's so important when you're advancing new technologies, that you have a method for not just saying what's in the clinical papers and does the FDA say. Those things that's standard. That's just the fabric of medicine. You have to have those things to be in the building and in the clinic. But every physician, every practice, that's why it's the practice of medicine. And that's what I love about being around medicine, is you have to try new things. Everybody's body is different. Every patient is different, and it will always be that way. So you have to have the ability and the flexibility to try new things, but it can't just be without control. So the data is so critical, and the more that we get, and the more that we can see what works best for what kind of patient, and the better that those outcomes can be delivered, and then more physicians come on more confidently. You're in the pioneer, the pioneer phase. Maybe not total pioneer,
maybe
but
the pioneer. I'm definitely not the trailblazer. The Centenos out there, those guys blaze a trail for us, pioneers moving our way out west. But they told us the place to go. So I definitely owe them a huge debt of gratitude, and certainly want to try to make that path even wider and easier for the next group of physicians that want to come down this road. Can I ask you a question?
Yeah.
So in the robotics, when you guys were first starting it to the point where now it's standard of care, how long did that take? What was that timeline? Like when at what point did that inflection kind of hit? Was it a 20-year thing and then all of a sudden it went, or?
No, it's so funny. That's a really, really great question. And I think it goes back to, you said the arthroscope, the scope in the operating room, the orthopedists call it the arthroscope. The general surgeons call it the laparoscope. The thoracic surgeons call it the thoracoscope. But in reality, it's exactly the same device. It doesn't, it's the same device that they process and bring it back into the room. And so it's the same thing with how the robot was adopted over time. The urologists were really the one. When I worked for Intuitive, was the company, and we used to say, we aim for the heart and hit the prostate, because the robot was designed for cardiac surgery. That was the original vision, because it just made so much sense. You're in this tiny space and you need to suture, and the ribs are, it's so morbid. Open heart surgery is so morbid and just absolutely a terrible recovery. And so that was the vision, was bring a robot in, let's do that. But it turns out the early robot just wasn't nimble enough to be in that kind of a procedure with a patient on pump and doing those cases. But all the while, there were urologists who ended up relying quite a bit on vascular surgeons to perform these prostate procedures because they were so morbid and lost so much blood. So the urologist said, there's got to be a better way. There's all these nerves and vascular structures and bones. It's a very, very complex procedure. It's totally routine now. They're doing it outpatient because of the robot. But back then, it was a major operation that always had a really high complication rate, or you're going to be incontinent and have erectile dysfunction for forever. That was the sentence when you had that cancer. And fast forward to the exact same thing happened to the doctor, the surgeon that you mentioned, the first robotic surgeon, lost privileges and, all kinds of things like, shunned from the community. But they pressed forward and really found a way to do that procedure. And to this day, it's still one of my favorite procedures to watch. And it's the most complex operation, but because they made it look so simple, everyone else in the next specialty that adopted is gynecology. And then it went, but it started from scratch. Every time you move into a new vertical and a new specialty, even if it's proven, it's not proven here. We have to now test it and assess it and integrate it into the way that specialty is trained and those new surgeries. But being the one that was really introducing the technology to physicians all along the way, and I got to see these different techniques, and I would say, well, the urologists, they suture and repair like this, and that seems like it would work very similar with this hysterectomy or this hernia repair or this, colon resection, so it sort of became like translating the technology all along the way, but you have to start from the beginning. And where the urologists had created a standard of care around, prostatectomy and partial nephrectomy procedures, then the gynecologist started, the GYN oncologists, they were the next ones to really pick it up for all the same reasons. It's, the same complexity in the pelvis. But even though they picked it up, then the next group of surgeons, well, we already know how to do minimally invasive and we don't need anything to do with this technology. And so it's, again, starting again. And once those early adopters figure it out. So to answer your question on how long does it take, it's really, a new adoption curve starts with every specialty. And I think that's going to be the same here too. The more I learn and meet physicians in the regenerative space, I think the physical medicine, rehabilitation specialty has really embraced it, or at least are the pioneers in my mind. They're the pioneers that have really set the tone for everyone else. And now we're starting to see coming to us for data collection, interventional pain, people just starting with this practice and wanting to collect data right from the start and make those comparisons. And it's, again, a very similar tune to when I was working with surgeons evaluating robotics. And we learned through that process that you have to collect data from the beginning, case one. And if you're not getting better outcomes, then you shouldn't do it. That's just that's the, that's not what we're in the business of doing. So I think it's the very, very much the same process. And we're now fortunate and me, I'm just so excited to get to be part of a company that is purely exists to help physicians understand the data and to bring that forward at in the personal practice, not just in the publications, but anywhere and everywhere that these procedures are being done, they should be evaluated and it should be accessible to the physicians that are doing those procedures. And I think we'll accelerate it even more safely than maybe what we saw with some of these other technologies. I mean, training evolves, the physician networks evolve, and you start to, training is a bottleneck. If you only have so many people who know how to do it really well, they can only affect a number of others because it's so hands-on in medicine. So we want to really empower more physicians to be able to teach others, and to do that, you have to have evidence to do that. It just isn't accepted otherwise.
And I think that's unique what we're talking about here, because unlike most things, there's no device to sell. Like when we mentioned the robot and the scopes, and there's really no sales here. This is truly just a platform to evaluate all these different products, not a single product, but all of these different products, and see which one works the best. It really is. It's a wonderful Pepsi challenge, if you want to call it. We're just going to see which one's the best.
See what happens. So let's say we find out that some aren't really so great. What is that? What does that conversation look like with the community?
That says I used to do this, and then I learned that it didn't work nearly well. So I tell people, like, I'll be the first one to change what I'm doing as soon as there's data that shows definitely that that's better than what I'm doing. If I'm getting, and I know I'm getting good outcomes, but I'm not 100%, not 100% of my patients get better. So what if my technique and what I think is best right now gets 72% outcomes on a given, but somebody else is doing something, they're getting 85% outcomes. Well, crap, what are you doing? Like, I want to do what you're doing. I'll be the first person to change. And that's, I think, what's so great about this open source platform is it really is everybody just saying, okay, here's my outcomes, show me your outcomes. And whoever is the best, let's all learn from you. Are you willing to share? Yes, I'm willing to share. It's not about going to a conference and, who's tallest, who's biggest, who speaks the loudest, who's got the most bravado or the most charismatic. Like, that traditionally has been who determines what everybody else does. And no, let's let stats prove it. Who's the best sport, athlete, pick your sport, right? It's based on stats. It's not based on how much they brag or how big they are or tall they are, or, what their 40-yard dash speed is. It's their performance on the field. So that's really what this is to me. It's a statistical grade. How am I doing as a doc? Like,
bar, yeah.
Am I batting above 300? Like, if I'm a baseball player, I'm doing pretty good, right? And how am I doing as a physician on my outcome? Am I getting? I want 70% outcomes. If I'm not doing something that's getting 70% outcomes, I don't know if I should be doing that.
Let's talk about that, actually, because the data is, this is another sort of adventure for me. I love data, everything about it. That's when I think about, people's hobbies and what they love to do. Some people like to paint. Some people like to play guitar. I like to make cool stuff out of data. That's my.
God bless you. Thank God there are people like you in this world. Because
So I found my calling here with DataBiologics. But part of this journey is looking at all of this data that all of you guys have been so diligently creating and putting into the system and getting your patients to respond, that we have so much, thousands of cases and all of these different products. But I don't know how to make any sense of it. So I have to start from, what are these questions that we're asking of patients, and what's meaningful? What is the score? What is an outcome? What does 70% outcome to you mean? Yeah. Like, let's break it down, because ultimately we got to show patients what this means. And, they don't have all the lingo and the jargon of it's the COOS survey and the ODI. And we have to really help them understand what is effective. What does that really mean?
So to me, at a patient follow-up visit, the three things I ask, are you happy with your pain control? Are you happy with your function? And would you do it again? If you knew that this was going to be what you're looking for. If I can't get 7 to 10 people to be saying yes to those 3 questions, then I don't think I'm doing a great job. Now, that's not something you can publish. That's not something you can really compare. So we use these validated studies when we do things like what we're tracking with DataBiologics, where you do a measure of people's pain that has been tested against various different kind of conditions. So it's a validated measurement of pain. And then you do the same thing for a validated measurement of function. And whether it's a shoulder problem or a knee problem or a back problem, that's going to be a different series of questions. And then adverse outcomes would be the third thing that I didn't include, but in my 3 examples, but definitely what we want to be checking is anything bad happening. Are people's pain going down? Is their function going up? And is anything bad happening?
Why is it so difficult for physicians to track data in everyday practice?
It's labor intensive. It's a process that either you have to do by having patients come back to your office, and people who are doing well don't want to take time away from what they're doing. They come to the office to tell you they're doing great. That's a waste of their time and money. So then it's, okay, I want to have my staff work this Excel spreadsheet and call patients every, so often and get a hold of them and ask them a series of questions. And I'm going to pay a couple full-time equivalents to be doing that, in addition to everything else that we're doing in our practice. It's timely, it's costly, and it doesn't end up getting you reimbursed anymore. There's no financial incentive to do it. It's just a curiosity, an academic exercise. So if you're not in an academic center that has maybe resources or undergrads or postgrads who are looking to do research, you just don't have the tools to do it. So you just assume if people don't come back, they're doing great. And that's not good science.
Nope, it's not. That's what we're here to do. Change that, make it easy.
Yep. And this is as easy as it gets. I mean, I'm a patient. I'm a DataBiologics patient. I get text messages and it takes me 5 minutes to fill them out, and it all goes into the database. And if I'm putting in the procedure notes and the information, it's 5 minutes or less. It's usually 2 to 3 minutes for me to put in the information, and you just build it into your workflow, and it becomes seamless. It's just something you do. It's just like filling out your super bill or doing your procedure note. I mean, whatever, signing your consent forms. It becomes part of your standard operating process, and it doesn't add any more time. It adds such minimal amount of time to your workflow. There's really no reason not to do it. And then it's so easy for the patients.
That's awesome. So your last question on this topic. So when you implemented DataBiologics, what did that look like with your staff? And then how have you worked it into the workflow?
So it was a stepwise process. I didn't jump right to what we're doing now. I'll start with what we're doing now. We do, as a part of our pre-procedure process, where patients are called to confirm their time, to confirm what they're supposed to do, if they're getting anesthesia, if they're not getting anesthesia. Oh, by the way, I'm registering for this patient registry. Are you okay doing surveys? You're going to get a text message. Here, I just registered. Did you get your text message? Can you please fill out your surveys before you come in? And then, as part of the pre-op, I come into the room before the procedure. I ask if they have any questions. I go over the consent form. I go over the fact that this is a FDA compliant but experimental procedure, make sure they understand that, sign all the consent forms, and then I log into DataBiologics and I check to make sure that they've been and have filled their survey out. If they haven't, I say, oh, I see that you haven't filled your survey out. Do you mind doing that while you're here? I'm going to send you a link right now. So we're sure to have that survey done before the procedure is done, before we draw the blood for a PRP, before we do the bone marrow aspiration for the stem cell. And then once the procedure is done, as part of my post-procedure workflow, I go in and do my procedure note, my EMR, and then I log into DataBiologics and I enter in all the data. It's just the next step after my procedure note.
Awesome. Excellent.
Before I did the whole thing. So I would, first implementing it, I didn't want to put it on the staff. I wanted to get my head around it. I wanted to understand how it worked. So I did that on the day of the procedure. I would log into DataBiologics, put in all their demographic information, and then send them a link and ask them to do it in the pre-op area.
Thank you, Dr. Nabity, for your time and sharing your story on our podcast today. How can our listeners get in touch with you? Yeah,
it was a pleasure. Thank you for having me. Michigan Center for Regenerative Medicine is the name of our business. RegenerativeMedicineMichigan.com, our website. We have a Facebook page. We have a Instagram page. I'll be honest, I don't make the posts, but I do contribute content. And you can certainly find us on those socials as well. But our phone number, 248-216-1008, probably the easiest way, just to give us a call if you're interested in hearing more, seeing if it's something you think we could help you out with. We do telemedicine visits. So even if you're not local to the Southeast Michigan, Metro Detroit area, we could still potentially give you an opinion and point you in the right direction, even find local providers close to you if you don't want to fly up here. But I'm happy to help out in any way we can.
Thanks to our listeners for tuning in today for the very first episode of the RegenMed SAGA. I'm your host, Leah Braddell, and this was Stories from the Front. Tune in next time for another informative episode, taking you through all of the stories that we find on the front lines in regenerative medicine, changing the future for patients.